Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This current series focuses on consent. I hope you enjoy it.
Welcome to the Reducing Risk podcast from Medical Protection. This is another in our series on consent. My colleagues Sam King and Lucy Gibbard are joining me, Tim Cookson, for today's session, which is on urgency but no consent. Frida Jones, not her real name, was an 85-year-old woman living in a unit within a rest home complex. She had a fairly straightforward past medical history, having been on antihypertensives for a number of years, a statin to help with her cardiovascular risks, and she'd had a left fractured neck of femur repair about 3 years prior. She had been living in her own home before the fracture and somewhat lost confidence, hence she had moved into the unit within the rest home. Now, Frida had no immediate family, but she did have a nephew who was listed as her enduring power of attorney, or EPOA, or the official title, which is actually attorney. However, the EPOA had not been enacted because, at that stage, Frida was fully competent. She had a good network of friends at the rest home and beyond the rest home, and was generally active and independent, and appeared to enjoy life to the full. It was fortunate that she was not living on her own, because during the evening meal, which she was enjoying with other friends from the rest home, she developed difficulty with her speech, followed by weakness of her arm and leg. She couldn't actually keep her balance on the chair and slid to the floor, which luckily was carpeted and did not injure her. The staff on duty recognised immediately that Frida was probably having a stroke and called an ambulance, which arrived promptly and took her to ED. The rest home staff tried to call her nephew, but were unable to contact him. On arrival at the tertiary hospital, there was clinical confirmation of stroke, and an urgent CT was arranged. The staff tried to talk with Frida, but she was not able to speak and did not appear to understand what was being said to her. The hospital team asked about the EPOA and were told that the nephew was not able to be contacted. They too tried the contact number and also got no reply. So, Sam and Lucy, the first question here is, Frida's obviously unable to give consent, judging by her sort of lack of any response to the questions that she's been asked. And so she can't consent to the CT. So should they delay the CT until they can get some other kind of confirmation of what ought to be done or some other consent?
That's a really good question, Tim, and I think that's probably one that faces our members on a regular basis. As we all know, you've got to start the thrombolysis fairly smartly, and so if you don't, she's going to end up with a far worse outcome. And there are other avenues where you can proceed without lawful consent, and given the situation, I would have thought, in fact, that most clinicians would want to proceed.
I think it's no doubt that it's in her best interest to have a CT, and I think there's very little risk in having a CT. So I think the question about doing a CT is relatively straightforward in that it is in her best interests. If she was able to consent, she probably would. And so I think that they're better to just go ahead and do it.
Yeah, and in the situation, they don't need to give contrast, and that's the thing that actually has the highest risk of complications with a CT. So, that seems like a sensible decision.
Well, under Right 74 of the Code, the Code of Consumer Rights, you can proceed according to patient best interests if there's no one who can actually lawfully give consent. And I think that, in fact, a lot of people are treated under Right 74, probably in the long term, and they can do that quite safely.
I think one of the things to to do is to document that you've thought about it, and that you've thought about the fact that you haven't got consent, but actually that you've considered that it's probably what she would have wanted. The people, her carers and people, have said that they think that's what she would have wanted, and it is in her best interest, so that's why you're doing it. So you've kind of show that you've thought about it.
Yeah.
And in this situation, they couldn't get hold of the nephew. In the ideal world, they would have gained the nephew's views, and the nephew hopefully would have had some view about what his aunt would have wanted, and in the ideal situation. But of course, this situation that you've put to us, Tim, that's not possible. So I would proceed safely under Right 74.
Good. So medico-legally speaking, you think that this is an appropriate thing to do. And they did, of course, and the CT confirmed that this was an ischemic event and not hemorrhage or a condition mimicking stroke. Frida was, therefore, as you pointed out, a candidate for thrombolysis treatment, and this needs to be given within 4.5 hours of the onset of the stroke, so it's pretty time critical. There were no absolute or relative contraindications to thrombolysis, and following the Australian and New Zealand living clinical guidelines for stroke management, the clinicians were keen to proceed with thrombolysis. So what sort of non-clinical factors do the clinicians need to consider in determining whether to proceed with this part of the process? And I think you've covered on some of those already in terms of finding out what she might have wanted herself, that kind of thing. Anything else you want to add to that, either of you?
Well, it would be good to ask the rest home if there's anything documented about what Frida's wishes would have been. You know, had she set up an advance directive or anything else where she had advanced care plan of what she would want in that situation. One of the problems with those, obviously, is that often people haven't anticipated exactly what's going to happen to them. So they're not always relevant, but they can at least give you an idea of what her wishes would have been. So it's a useful thing to ask the rest home or the GP if there's anything on her records.
I think that's a good idea. The GP is often a really good source of information because of the longitudinal relationship they have. I think the difficulty, as we all know with advanced directives, is it valid? And in the urgent situation, most clinicians would probably find it very difficult to know that it is valid, and therefore you would proceed as though it's not valid, if that makes sense.
Yeah, I think it.
I think it is
very tricky.
It is that whole idea of, did the patient anticipate this exact situation that has occurred and tell you what they would have wanted? And obviously, because there's a multitude of things that can occur, they often haven't anticipated it. So the advance directive may not quite fit what's actually happened.
Yes, and this statement, I don't want any life-prolonging intervention when I'm in a vegetative state or whatever, doesn't quite cover this kind of scenario, does it?
No. I think if there's doubt about the validity of the advance directive, people would say, yes, let's save life.
Yeah.
Yep. And that's certainly the fallback position, I think, that is recognised in law, that you have when in doubt, there's a preference for life-saving intervention. Yep. The other question that might come into this is whether her age of 85 has a bearing on this decision. And, of course, for some acute situations, age will be a factor, but apparently in this case, the evidence suggests that patients over the age of 80 actually have a slightly better likelihood of a good outcome than those under the age of 80. However, they also have a greater risk of intracerebral hemorrhage, which is, of course, the complication that you don't want. Now, the guideline states that the pre-morbid level of function rather than the chronological age should be considered when deciding whether to treat. And the guideline also states that, quote, benefits outweigh harms for almost everyone. So it's a pretty clear kind of statement for the team to be guided by. They try again, but the nephew is still uncontactable. And so then who else would the clinical team discuss the situation with to try and determine whether proceeding would be something that Frida herself might have elected to do if she had been able to give consent? And you've talked about the rest home. There might be, talked about the GP, there might be friends at the rest home who might be able to provide that information. So there's no formal consent obtainable because the nephew can't be contacted. And in our situation here, the treatment proposed is not life-saving, but it's life-improving. And that is different. Those two things are different. So if you've got someone who needs an urgent operation because of their whatever it is not operated on, then the outcome is going to be bad very rapidly. Whereas this is more about degrees of outcome rather than absolutes. Is there anyone else from a medico-legal perspective that the clinicians might speak to, in this case, to protect themselves as much as possible?
I think spreading the risk is always a good idea. And so speaking with senior colleagues is really helpful. And if you do have a legal team at your hospital, which many do, then you could speak to the legal team. And the other thing you can do, of course, is contact your indemnifier for some advice. I think in this particular case, and I don't know what the answer is, but it's about the risk of an intracerebral hemorrhage. It might be less than 1%, in which case we would consider it rare. But if it was 30%, I think you're talking about a different scenario. So I think talking over the specific situation for this specific patient is a good idea.
In this case, and not being an expert myself on this, but the guideline states that it's about 3.5% for someone over the age of 80.
Okay.
The clinicians were aware that the time for potentially successful intervention was rapidly approaching, and they do decide to go ahead with reperfusion therapy. They don't actually speak to anybody else, the hospital team or their indemnity provider, and they felt that because of the time-critical nature, they just needed to get on with it. There were no immediate problems following the injection, and the next day Frida had measurably improved, which was, of course, the outcome they were looking for. However, later that day, she suddenly collapsed and lost consciousness. An urgent CT confirmed that she'd had an intracerebral hemorrhage, and she was given palliative cares and died 2 days later. So, is this a death that would need to be reported to the coroner?
Yeah, well, that's a question, isn't it? It all depends on whether you consider thrombolysis to be a procedure, because if it's considered a procedure, then and she died as a consequence of a procedure, which it seems like she may have done, you would have to report that to the coroner. But then I'm not actually sure that providing a medication is what would come under the definition of a procedure. So I would say it's a little bit grey, really. And in those situations where it's grey, I think it's often quite a good idea to pick up the phone and talk to the duty coroner and ask them. Because often the duty coroner, if you talk through it, will say, oh, look, no, are you happy to, you do know the cause of death? And they will often say, no, you're fine to write a certificate. If they considered it to be a procedure, they may not say that, and they may want to take jurisdiction.
You're not going to get in trouble by calling the coroner and having a discussion, whereas if the coroner subsequently finds out and they believe that it should have been reported, it can be a little bit sticky.
Yeah, and I guess the legal team at the hospital could also give some advice on that as well, couldn't they? Okay, so it's the coroner. Are there any other inquiries that might be needed? And we know that the Health Quality Safety Commission is keen on having events reported to them. What are your views on whether this is an event that ought to be reported to the HQSC?
I think that's a really interesting question. I don't know what in practice happens in hospitals. If you have a look at the SAC rating or the severity assessment code rating that you find on the HQSC website, it says that a SAC 1 reportable event is where there's been a death or permanent severe loss of function not related to the natural cause of the illness, differs from the immediate expected outcome of the care management, can be sensory, motor, physiological, psychological, or intellectual. So technically speaking, this is a death that isn't related to the natural course of the illness and differs from the immediate expected outcome from the thrombolysis. So technically it could be reportable. In practice, I'm not sure that these things would be. Lucy, what do you think?
I think it meets the criteria for a SAC 1 inquiry, I have to say. But yeah, whether or not that is what would normally happen in this situation, I think it's because it is a known adverse event. I think particularly in this situation where actually we didn't get consent from the EPOA or from the patient to go ahead with the with the treatment. I think that would kind of push me more towards actually there should be a SAC1 inquiry. I think if you had talked to the patient and told them about that 3.5% risk of a bleed, and then that subsequently happened, I think that would probably, it's still an adverse outcome for the patient, but a little bit safer ground than where that treatment's been provided based on Right 74.
I think in reality, if you presented to the family, if we don't treat, then she's got permanent and severe vulnerabilities or morbidity here, versus treating her, she's 97 or 96.5% more likely to have a good outcome. Most families are going to say we should treat, because 3.5% risk is still relatively low. That's in practice. But you don't know how families will react to these sorts of situations, and they might come and say, well, you did the wrong thing, etc. So when the family generally are agitating, it's often better to investigate than not.
Mm-hmm. So at the very least, the clinicians need to consider whether or not they need to make a SAC1 notification or a notification. The other thing that we often see, isn't it, with the HDC complaints, is if a complaint's gone to the HDC and it's been an event like this, that's often one of the questions that the HDC asks. Has there been an internal investigation? What are the results of that investigation? So if you're anticipating that there could be problems, then actually, as you say, Lucy, that might be the right thing to do, to err on the side of caution.
I think the other thing to remember here is a CALM report. Actually, I think we don't do enough CALM report, but this is an adverse reaction to a medication, and a CALM report would be a good idea just for notification purposes.
So the nephew returned from his overseas holiday some 3 weeks later and was shocked to hear that his aunt had died. After getting a summary of events from the rest home staff and learning that Frida had almost certainly died as a result of her stroke treatment, he lodged a complaint with the HDC. His main concerns that he expressed in that complaint were that the intervention was too risky, should not have been done for someone of Frida's age, and that no consent had been given. So is this something that the HDC would take seriously, or will they just say, no, this is an elderly 85-year-old and no problems here, go away?
I think there's no doubt the HDC would take it seriously. I think the HDC are very keen that consent processes are considered and done carefully, and so I think it is definitely something that they would look at. Particularly because of the fact that there wasn't an EPOA available to consent.
Yep, and the HDC has certainly been very interested in consent issues for many years, and they also take particular interest where there's been a medical intervention that's led to a serious outcome. I think there are two factors there that would be significant, and true enough, the HDC decided to get an expert to review the case. And so what are the important factors that the expert's going to consider in this case? I think actually we've covered most of them already, which would be, what efforts were made to contact the EPOA, what efforts were made to determine what Frida herself might have wanted, if the guidelines, which there were they appropriately followed, what was the quality of the documentation, which you talked about, Lucy, before as being very important. And they might consider what efforts were taken to try and ensure that the medico-legal position had been clarified. But actually, an expert may not even think of that. So that may not be something to consider. Now, it's worthwhile going over Right 7 again of the Code of Patient Rights, and this states under Section 4 that where a consumer is not competent to make an informed choice and give informed consent, and no person entitled to consent on behalf of the consumer is available, the provider may provide services where A, it is in the best interests of the consumer, and B, reasonable steps have been taken to ascertain the views of the consumer. And under a subsection, if the consumer's views have not been ascertained, the provider takes into account the views of other suitable persons who are interested in the welfare of the consumer and able to advise the provider. And in this case, the rest home staff member who came had known Frida quite well and was able to give a reasonably clear view of what she thought Frida might have wanted, which would have been for intervention to occur. Actually, I have to confess, there was no complaint to the HDC, and looking through the decisions that have been published, specifically relating to this kind of scenario, I couldn't find anything. There are 2 decisions relating to thrombolysis in acute stroke, but these both involve incorrect dosing of the thrombolysis. Now, although we've used acute stroke management as the example, the principles we've discussed relate to any scenario where urgent treatment is required and consent is not available. Now, where the treatment is clearly life-saving, as we've mentioned, the decisions are a little easier. However, where this is not the case, then careful consideration is needed before deciding on the best course of action. Before we finish, let's briefly consider what might have happened if the nephew had been immediately contactable. So, Lucy, the EPOA hadn't been enacted. So, officially, does the nephew actually have any rights at that moment as the attorney?
Well, she is. I think that she's not competent, though, by the time she is in hospital. And so in that situation, the attorney, it would be appropriate to activate the EPOA at that point. And for any significant decision, you would want to activate it. So I would say that actually, as long as she wasn't competent and she wasn't able to speak and give her views, then it would have been appropriate to activate the EPOA at the time she was arrived at hospital.
Yep. And so, Sam, what actually would be involved for the clinician in terms of activating? What do they need to do? Is there a special certificate that they need to sign? Or is it just a bit of paper saying, I have assessed this person and she's not able to she's not competent to make this decision?
In that particular moment where they're wanting to provide urgent treatment, so long as it's documented that they've assessed competence and that she's not competent to make her own decisions, then that's enough. They can act upon that, and the nephew can act as the EPOA. In general, you would fill in a form, or it's called a certificate of capacity, and you would send that to the patient's lawyer. So then it can be officially stated that the EPOA has been enacted. But you don't have to wait for that.
But you don't have to wait.
No.
I think in ED, all you need to do is write down patient unable to communicate, unable to provide consent, EPOA present.
Yeah. And the other thing too is that there's actually an expectation that if she responds to treatment, she will become competent.
That's
again.
right.
So this is just a temporary certification of her lack of competence rather than something that's committing everyone permanently to saying she's no longer able to make decisions about her own health care. So, but it certainly would make it clearer for everyone if some kind of documentation has said, yes, we have made that decision that she is not competent, and therefore that the nephew, as the attorney, can make decisions on her behalf and give consent on her behalf.
And the moment she becomes competent, or a patient becomes competent, then you can say the EPOA is no longer able to make decisions for her. And similarly, that would be immediate as well. Although, again, you'd probably want to fill out another certificate of capacity and pass that to the lawyer just to make it all official. But you can act immediately upon your assessment. One of the things I would like to just mention to our listeners is the importance of documentation. Explaining your rationale for the decisions you've made, the people you've discussed it with, to arrive at your conclusions is really important when there's been a complaint. And I think that for most clinicians, they follow a good process, except they don't necessarily document it. And, if something happens 3, 5, 6 years down the track where there's a complaint, it's much easier if you've documented well.
And do we feel that our colleagues do that particular bit well? Or is it an area for improvement?
I think it is definitely an area for improvement. I think the problem with the EPOA system does have some issues with it, and that the fact that EPOAs aren't registered anywhere, so it's awful hard to know if someone's even got an EPOA. I mean, in this situation, we were lucky the rest of them knew about the EPOA and who it was, but so often you get left scrambling with, well, have they got an EPOA? So you're even one step back. But I think there are lots of issues around this that can create pitfalls for clinicians. But the more you write down about what you've thought about and who you've talked to, and what you've considered, the better the outcome is likely to be if there is a complaint later.
I don't think that you'd be criticised if you made a reasonable effort under the circumstances, and in this case there was urgency, to determine if there was an EPOA holder or not. And I don't think you'd be criticised at all in this situation if they found out, yes, there was an EPOA holder, but you've treated under a Right 7-4. I think they would have done the best thing for the patient.
Yeah, so if she'd been at home and she'd pressed a buzzer, for example, to call the ambulance, it might have been only the GP had that information about the EPOA, and this was a Saturday evening. So, that information is not obtainable, absolutely. There's a final curly thing that we might briefly discuss is, what if the nephew declined to give consent for thrombolysis despite being fully informed about the likely benefits and risks?
Yeah, well, the EPOA has to act with the patient's best interests at heart, and their whole role is to promote the welfare of the person who has given them that EPOA. So I think that you've then got a very difficult situation where you think maybe the attorney is not acting in the best interest of the patient, and that's very tricky, because actually the EPOA is the representative of the patient. The patient's chosen them, and it's a much more difficult thing to go against an EPOA. I would definitely be picking up the phone to your indemnifier or talking to the hospital lawyers if you actually wanted to do something different from what the EPOA is saying. I mean, the other question is, would it be considered life-saving? Because an EPOA can't refuse life-saving treatment. And so would you consider providing a thrombolysis is life-saving? I'm not sure, but the EPOA couldn't say no if it was considered life-saving.
Yeah, I think the issue here is that actually it's not life-saving, but it's life-improving, and so it does introduce that possibility. I don't think there's any absolute answer to that particular one.
No, I don't think there is. It's a tricky one.
But I think it sort of sums up that in this scenario that we've been talking about, where you've got a need for provision of urgent medical care, but consent is not able to be obtained, there are a lot of things that need to be considered in amongst the clinical rush that you have to actually do what you need to do within the time set frame. So it's not an easy scenario, but we hope this has given you some ideas on the kinds of steps that you might need to think about if you're in a similar situation. For those who are interested in the specifics of the case, there's the 2017 Australian and New Zealand guidelines, but they actually don't have any specific guidance on this issue of consent. There is, in the Journal of the American Medical Association, Urology, an interesting paper covering consent for thrombolysis, and if you're interested in that, you could contact us for that reference. Thank you, Sam and Lucy. Enjoyed that.
Thanks, Tim.
Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review.